our lecture, which is the retina or the posterior segment disorders. Let's start first by a very common, but common if you are working in the pediatric retina. But if you are not working in the pediatric retina, you may accidentally encounter it, and sometimes it is misdiagnosed, or sometimes may surprisingly diagnosed intraoperatively while you are doing other procedure, which is the persistent hyperplastic primary vitreous. What is the persistent hyperplastic primary vitreous? Sometimes it is called PHPV, but now it is the most recent name to it. Now it's called PFV, or persistent fetal vasculature. So what is the persistent fetal vasculature or persistent hyperplastic primary vitreous? We know that during the embryonic life, there will be regression of the hyaloid vessels. In the last trimester, the hyaloid vessels, there will be hyaloid vessels that will supply the lens and the anterior segment. This is called the canal of Cloquet, extending from the optic disc to the lens. And these blood vessels are branches of the hyaloid arteries surrounding the lens by what's called tunica vasculosa lentis. So those blood vessels should disappear by the end of embryonic life. However, in some cases, they don't disappear. So they will persist, leading to what's called persistent hyperplastic primary vitreous, or persistent fetal vasculature. This is the more correct name. Those patients will be present with unilateral microphthalmia, very important for the MCQ exams. Unilateral microphthalmia. And those patients can present with a spectrum of findings. There are like 4 stages of this disease. Not always are present the same. Like this disease, let me just explain to you. This fetal vasculature started by the optic disc, then this stalk of canal of Cloquet canal, then this bag enclosing the lens, and when they absorb, they will leave a dot present in the lens, back of the lens. It's called the Mittendorf dot. It could be that the whole system is persistent, or only a part of the system is persistent. So the distal end of this system, it is called the Bergmeister papilla. It is like a tissue present at the optic disc. It looks like a trigium, and this will be the most distal end, and the most proximal end will be what's called the Mittendorf dot. We will talk about it in the lens section. And so it will be a spectrum of findings of prominent hyaloid vessel remnants. These are the remnants of the hyaloid vessels. This can be sometimes large Mittendorf dot, Bergmeister papilla, or angle closure from the fibrovascular invasion of the lens through the posterior lens capsule. So this will be due to incomplete regression of the tunica vasculosa lentis and the primary vitreous. It is sporadic. 90% of cases are unilateral, and findings that those patients will have small eye or microphthalmia. This is very important. Vascularized retrolental plaque sometimes may contain cartilage, shallow anterior chamber, and iris vascularization. You see, this is a partial or incomplete persistent fetal vasculature, but this is the complete. This is extending from the optic disc till the back of the lens. So those patients can have cataract. So that's what I'm telling you. You may accidentally find it, like you are operating on a pediatric cataract and you don't know what is behind. So once you remove the lens, you will be surprised that there is a stalk behind the lens of the persistent fetal vasculature. Also, they can present with angle closure glaucoma, vitreous hemorrhage, or retinal detachment, which is a very common presentation. They also can have show traction of ciliary process. So you will find that ciliary process are very visible on dilated fundus examination, which is not the case in normal occasions. Treatment depends on the case or depend on the spectrum. Like if it is just a Mittendorf dot or it is just a Bergmeister papillae like that, then you just do observation. Or if there is invasion of the lens, you can do lensectomy. If there is a retinal detachment, you can do vitrectomy. So it will depend on the case. Not all the cases are the same. Finally, the final condition that we are going to discuss today is the retinopathy of prematurity. So what is the retinopathy of prematurity? It is a retinal condition occurs due to ischemia, vasculogenesis, and angiogenesis that happens due to immaturity of the retina and oxygen exposure during the in the incubation or for the preterm babies. So actually for the preterm babies, they will be receiving supplemental oxygen. The supplemental oxygen will be responsible for doing for the ischemic retina to release angiogenic factors. This angiogenic factor will cause new vessels that will later on will cause fibrovascular membranes and contraction, eventually causing retinal detachment. So starting first about the classification. So the hardest thing about the premature retinopathy of prematurity is the classification. So let's see how can we classify a retinopathy of prematurity. In the retinopathy of prematurity, we classify the retina into zones. Zone 1, these zones are 3 zones forming 3 concentric rings. The first zone is the central one, or zone 1 is a zone with a center of optic nerve, and the diameter of this zone is double the space between the optic disc and the fovea. Again, zone 1 is the zone which is centered with the optic disc, and its diameter is double the distance between the optic disc and the fovea. Okay. Zone 2 is a zone which is concentric with the zone 1, which is extending from the nasal ora serrata. Here is the nasal ora serrata. So it will be it is a zone also centered in the optic disc with with its boundaries reach to the nasal ora serrata. Here is the zone 2. You will find that there is a remaining temporal crescent. And this remaining temporal crescent is what's referred to as zone 3. Okay, so again, zone 1 is the central zone which has the optic disc as its center, and its diameter is the double distance from the optic disc to the fovea. Zone 2 will be the concentric ring which extended up to the nasal ora serrata here. And you will find that there is a remaining temporal crescent which reach to the temporal ora serrata, and this will be the zone 3. Here, zone 1 in the center, zone 2 in the mid-periphery up to the nasal ora serrata. Zone 3 is at the temporal ora serrata. So these are called the zones. Zone 1, zone 2, zone 3. Then we have another classification by the stage. It depends on how much progression of the retinopathy of prematurity. So retinopathy of prematurity starts by what's called the demarcation line. Demarcation line, it is a line, flat line, separating the vascular retina from the avascular retina. You can see there is no vascularization here, and this is here are the blood vessels are trying to reach the avascular retina, but they are unable to reach that. So there is a line separating both of them. This is called the demarcation line, or the separating line between the vascular and the avascular retina. Then this demarcation line will widen and thicken. So it will increase in the horizontal diameter and it will increase in the vertical diameter or becoming more thick, more elevated, leading to formation what's called a ridge. A ridge is a stage 2. Stage 2 is when the demarcation line become more wide and more thick. Okay. Then what happens after stage 2 is stage 3. In stage 3, there will be development of fibrovascular proliferation. So there will be blood vessels and fibrous tissue are starting to form at the junction between the vascular and the avascular retina. Stage 4, when the fibrous tissue starts to contract, and this contraction of the fibrovascular tissue will cause retinal detachment. But this retinal detachment is subtotal or extrafoveal, so it doesn't involve the fovea yet. The macula is still attached, but it will just cause subtotal retinal detachment. If this involves the fovea, or if there is a total retinal detachment, then this is called a stage 5. Stage 5 retinopathy of prematurity or retrolental fibrodysplasia. This was the old name, like it was thought before that this is like a mass behind the lens, and this mass will cause a whitish color. So it was found that it was like was thought in the beginning that it is like a tumor or a retinoblastoma or a mass behind the lens. So that's why it's called retrolental fibrodysplasia. But this term is maybe not used now. It's just a stage 5 ROP. So let's see this in actual cases. This is a demarcation line. You can see that there is a line of separation between the avascular retina and the vascular retina. Then stage 2, in this demarcation line is transforming into a ridge. You can see the difference in color between this line, which is now becoming a ridge, and the rest of the avascular retina. It's clearly seen that it is thickened and widened separation between the vascular and the avascular retina. Then this ridge is forming fibrovascular proliferation. All these are blood vessels with fibrous tissue, but the retina is still on. There is no retinal detachment. Then stage 4, there will be subtotal retinal detachment without involvement of the fovea. So here is the retina looks elevated. There is a pull from here. So there will be a subtotal retinal detachment without foveal involvement. And this will be called the stage 4A. If there is a subtotal retinal detachment with foveal involvement, it is called stage 4B. So this is a retinal detachment, but unfortunately it involves the fovea, so the fovea is detached here. If it is becoming total retinal detachment or total RD, in this case we call it as a stage 5 ROP. Okay, so this is another classification. So we talked about the zone classification, zone 1, zone 2, zone 3, and stages classification, stage 1, stage 2, stage 3, stage 4, stage 5. There is another parameter or another, let's say it is a stage, but it can be added to any stage as a risk factor or a dangerous sign. It is called the plus disease. So we can say that it is every case or like stage 5 with or without plus disease, stage 4 with or without plus disease. What is meant by the plus disease? A plus disease indicates the seriousness of the condition, the more tendency to progress. So the plus disease can be marked by specific signs. First of all, the engorgement and tortuosity of retinal blood vessels, or the presence of vitreous haze, or the presence of engorgement and tortuosity of blood vessels at the pupillary border, or the difficult pupillary dilatation. All these signs mean that the patient has a plus disease and he has a tendency to progress very rapidly. Okay, so those patients who are present in the incubators and they are receiving oxygen, not all of them will develop retinopathy of prematurity. But if they develop and it will pass silently without management, it will be blinding for those patients. So how can we screen those patients? How can we detect those patients before the condition progress? So how do we screen the retinopathy of prematurity? Who, when, and how we observe and how we treat? This is what we are going to discuss now. Who we are going to screen? Those patients or those preterm babies who are waiting or weighing has a birth weight of 1,500 grams or less. So is this a sharp number? No, we even can screen those babies who are weighing even up to 2,000 grams if they have concurrent morbidities, like if they have cardiovascular problems or respiratory problems. Those patients also can be prone to development of retinopathy of prematurity, even if they have more weight. And who are going to screen the mothers who have 32 weeks of gestation. So the baby has 32 weeks of gestation. This will be also an indication for screening of retinopathy of prematurity. So when we do the screening is at 32 weeks of gestation or at 4 to 5 weeks postnatal. Again, who should we screen? Are babies with 32 weeks of gestation or 4 to 5 weeks postnatal in order to give a chance for the new vascularization to develop or for the changes to develop. So how can we develop or how can we follow up these patients? We follow up those patients weekly or every 2 weeks, depending on the stage, depending on the zone, depending on the progression. So our aim is that the vascularization will reach the zone 3. We can even do more close observation in patients who have what's called pre-threshold type 2. We are going to discuss this right now. And who are going to be treated are the patients who have a disease or a condition. It's called the pre-threshold type 1 or threshold disease. Okay, so these are the indications of treatment, and we are going to discuss the treatment and these threshold or pre-threshold right now. Dr. Atif, please repeat the plus disease. Okay, the plus disease is when we find that the patient has retinal vascular tortuosity, or they have a vitreous haze, or they have iris tortuosity, blood vessels tortuosity at the iris, or they have difficult pupillary dilatation. These are indications of more incidence of progression and more serious disease. Okay, so these are the screening criteria. So what is meant by threshold and pre-threshold type A or type B or type 1 or type 2? Remember these zones, the zone 1 and zone 2 and zone 3, we can classify the involvement by clock hours. So these are 12 clock hours. So depending on the number of clock hours involved, we can say that it is a threshold. So what is meant by threshold? Do you see this picture? And this picture, if they have involvement in zone 1 or presence of involvement in zone 2, and this involvement will be, so it is 1 or 2. This involvement, it can be either as a 5 clock hours or 8 clock hours. 5 non-contiguous clock hours, or sorry, 5 contiguous clock hours or 5 continuous clock hours, or 8 non-contiguous or non-continuous clock hours. So if we have affection of zone 1 or zone 2, either 5 continuous or contiguous clock hour or 8 non-contiguous or non-continuous clock hours with plus disease, in this case, this is an indication for threshold. So again, if we have here a disease, ROP, In zone 1, here is zone 1, this involvement in the center, zone 1, involve 5 continuous clock hours or non-continuous, or 8 clock, or so this is like 5 continuous clock hours or 8 non-continuous clock hours with presence of plus disease, then this is called a plus disease. Or involvement in the zone 2. In the zone 2, you will find the presence of involvement including 5 contagious clock hours like that, or 8 non-contagious clock hours. Presence in the zone 2 with a plus disease, this is an indication for treatment. But so in order to remember it, remember 1 plus 2 plus 5 equals 8. So stage zone 1, zone 2, 5 contagious, 8 non-contagious, and add the plus signs for the plus disease. This is called a threshold disease, but actually for current practice, we don't wait for this level. We just treat for the pre-threshold type 1. So what is meant by a pre-threshold type 1, which is an indication for treatment? A pre-threshold type 1 so means that any stage present in the zone 1 with a plus disease. So if you have any stage present in zone 1 with plus disease, this is a pre-threshold type 1. And this is an indication for treatment. Or if you have stage 3 in zone 1 without plus disease. So this is an indication of treatment. Or if you have a stage 2 or a stage 3 in zone 2 with plus disease, this is an indication for treatment. Again, if you have any stage in zone 1 with plus disease, if you have any stage, any stage 3 in zone 1 without plus disease, if you have any stage or stage 2 or 3 in zone 2 with plus disease, these are the pre-threshold type 1, which is an indication for treatment. Pre-threshold type 2, which is an indication for close follow-up, maybe week or less, are stage 1 or 2 in zone 1. So we said that in state if the without plus. So if it is a stage 1 or 2 with plus, this is an indication of treatment. If it is a stage 1 or 2 without plus, this is an indication for close follow-up, as it is now pre-threshold type 2. If it is a stage 3, then it is now indication for treatment. You got it? So again, for zone 1, if it is a stage 1 or 2 without plus, wait. If it is a stage 1 or 2 with plus, treat. If it is a stage 3 without plus in zone 1, then treat. Okay. The other type of the pre-threshold type 2 is the presence of a stage 2 or 3 without plus. So if it is stage 2 or 3 with plus, you treat. If no plus, then you wait. So you see that the importance of the plus disease here, that it will guide you for treatment. So to summarize, the ROP can be classified into two different categories. The mild ROP is the absence of plus disease with stage 1 or 2 in zone 2, or any stage in the zone 3. Type 2 ROP, or pre-threshold disease, is the absence of plus disease with a stage 1 or 2 in the zone 1 or stage 3 in the zone 2. So close observation is required. Type 1 or pre-threshold 1 is a plus disease with any stage in zone 1 or a stage 3 without plus disease in zone 1 or a stage 2 or 3 with plus disease in zone 2. In this case, treatment is required. How can we treat? If the lesion or if the involvement in the zone 1, we do anti-VEGF injection. If with a lesion or involvement in the zone 2, we do laser application. There is a specific type of ROP which is called aggressive ROP, and this is a severe form with high risk of progression with prominent plus disease. There will be highly engorged blood vessels, ill-defined retinopathy that may present in the posterior location, in those patients should be treated with anti-VEGF in zone 1, again with laser in zone 2. Okay, so I hope that this will be a difficult to memorize this slide, but this slide, if you are trying to just visualize it like a diagram like that, it will be much easier to remember these stages. So how can we treat those patients? Even in the past, in like more than 40 or 50 years ago, those patients were candidates for cryotherapy, to do application of cryotherapy over the retina from outside. This will lead to destruction of the ischemic retina. So this ischemic retina will not release the anti-VEGF, causing a scar. But nowadays, those patients can now be treated by the laser photocoagulation if the involvement in the stage 2, in the zone 2 or zone 3, those patients can be candidates for laser photocoagulation. By doing laser, we are doing destruction of the retina, causing this retina will not release the angiogenic factors, so they will not cause a new vascularization, which will cause later on fibrovascular proliferation and contraction and detachment. So this will be a treatment for zone 2 and zone 3. If the lesion is in the zone 1, we don't have any treatment except the anti-VEGF. So anti-VEGF will be antivascular angiogenic factors, and will be used for zone 1 management, and for stage 4 and for stage 5, where there is retinal detachment, there is no management except for the parsoplantar vitrectomy with guarded prognosis in the stage 4 and the poor prognosis in the stage 5. Okay, is it clear? Any question? Easy, the pediatric ophthalmology? Easy or difficult? Okay, thank you very much. Thank you, Dr. Rami and Dr. Kinana. You are my biggest supporters from the FRCS3 group. Okay, thank you, Dr. Atif and Dr. Hagar. So thank you very much for your attention. We will, next lecture will be our first MCQ lecture. So we will focus on the MCQs that appeared in the ICO and the FRCS2 exams before. So it will be like an interactive discussion, and it will be like in the form of competition and prizes for the winners. So it will be like a lovely atmosphere. I hope that you will all participate and join and solve and win. So it will be the next lecture, inshallah. Please prepare yourself well. Try to catch up what you missed over the last pediatric ophthalmology and strabismus and the neuro-ophthalmology, to be ready for the interactive discussion. Okay, thank you very much, and see you in the next lecture.